Okay, so today's lecture is very, very important. Not today only, but this chapter. So we will discuss it over probably a couple of lectures. So today we're going to start with fluids, and then we'll get into electrolytes, and then eventually acid base. So so when we talk about fluid, body fluid, who wants to give me a little idea of what do we mean by that? When we talk about body fluid, what is this? How is it related to your profession? Why is it important? What do you need to look at when you talk about body fluid?
You need to see if people are retaining more than what they should be.
Yeah, it has a lot to do with what, basically? Trying to do what? To balance things out, right? That's what we mean by that. So your job as a nurse is to make sure that everything is balanced. All the fluids are balanced in the patient's body. So you monitor the fluids. You monitor their body fluids. So when our body fluid in general is divided into different compartments. Okay, so compartments, it means that the body fluid is located in certain areas in our body. Now, who has more body fluids than the other, female or male, usually?
I would think female has more.
Like male.
Male has more fluid, with about 5%. Who has more fat than
Female.
men or woman has more fat?
Female.
What's that? Female.
Female.
Female has a little bit more fat, correct. So females have, because of the fat that they have, that substitute for the fluid. So eventually the woman has less fluid in them. So the more fat you have, the less body fluid, overall body fluid that you would have. So let's say that you're an obese person. So if you're an obese person, eventually you will have more fluid in you, even though your body is bigger size-wise. But the fat takes place of the general fluid in general. So your compartment, the body fluids are fluid that has things in it. Usually, it could be clear fluid, but usually we find it in inside our cell. Okay, and that is called intracellular. Okay, so when we find the fluid inside our cell, it's called intracellular. If we find it outside the intracellular, then it's called extracellular. So the extracellular is outside the blood vessels. And that's usually either you find it in between the cells, okay, or you find it in the plasma or the blood. Now, someone has their microphone on. It's really turn off your microphone, please, if you have it on. So automatically you need to understand that the majority of the fluid basically sits inside the cell, and then outside the cell we have less. So in general, the extracellular fluid, we have about let's say 40 liters of fluid in our body, all over, distributed all over. So 25 liters will be inside our cells and 15 liters will be outside. Now, out of the 15 liters, I have 12 liters that sits in between the cells, which is referred to as interstitial fluid. And then 3 liters sits in the plasma. And then we have another 2 that sits in other areas in your body. But they're all part of what we call the extracellular. So the 2 extra liters that we have, the 3 liters that we have would include the plasma, but we have within all that fluid, we have fluid that comes out of the plasma and goes into other areas. So 3 liters in the plasma, 12 liters in between the cells. Out of the 3 liters that we have here, some of the fluid comes out from there and goes to different areas. What areas do you assume it will go to?
The legs?
So some of the fluid from the plasma are excreted out. So from your blood, you have fluid coming out and it goes into different parts of your body. What parts, what organs do you think have fluids in them? That's not blood. That is not considered blood.
Your
What are
kidneys?
It's kidneys. Okay, kidneys, you have urine, right?
Would it be your stomach?
In the stomach, you have fluid, little fluid, but what specific areas you have fluid?
Your small intestine and large intestine.
Okay, small and large intestine, you'll have little intestine that comes out of the, drinking water and then the feces and all that. But
Your
how
mouth?
about, go ahead.
Your mouth?
Okay, how about synovial fluid, for example? You see, synovial fluid is found where?
And your joints?
Okay, give me another fluid that you have. Another name of fluid.
Fluid?
CSF?
CSF, cerebral spinal fluid. You see, all these are fluids that comes out of where, basically? Out of your blood. So fluid comes out of the plasma and it goes into different parts of your body. How about your eye? Does it have any fluid there?
Yes.
Yes. And what do you call that fluid? Anybody knows?
Lacrimal fluid?
Yeah. Well, lacrimal fluid is in the tears, which is fluid also. But inside the eye, what do you call those? Call that humor. Remember? So aqueous humor and vitreous humor. Remember that fluid inside your eye when you did the eye? All right. So that's the story. Now, so all the fluid that you have inside intracellular fluid, that means inside the cell, must be balanced with the extracellular fluid. If it's not, if there's a shift from one side to the other, then we have an issue. So you need to understand what is an intracellular fluid, what is an extracellular fluid. So if you lose fluid through your intestine, what are you losing, intracellular or extracellular?
Extra?
Yeah, and specifically, now we could have fluid also interstitial. When I say interstitial, it means in between, right? So the fluid inside, in between the cells. So this is the compartment that actually you move cells from one to the other, anyways, but I'll get to that picture in a second here. But this one actually talks about the different fluids inside. So who has, out of these different ages, who has the most fluid in them?
Neonate?
Infant.
Neonate, you see, and then infants, and then children, and then adults. Okay, and then a female, average 50 to 55, so here it says 55, but here 50, but average 50 to 55, depending on their body weight. Okay, there is a way we calculate fluid depending on your body weight. Okay, and that would be your percentage. So 50% of whatever kilogram you are is water, or 55%. So take your weight and multiply that by 55%. That tells you exactly how much your total body water. All right. So roughly about 40 liters of your whole body is water in general. But we can calculate it exactly by multiplying 60% in this case of your body weight, and then that would give you how many liters of water. Okay, that's one thing that you need to monitor as a nurse, and to find out like what percentage body water should this person have. And if it comes down a lot, then they can go into what we call dehydration. If it goes over that, then they can go into what we call overhydration. Okay. So, so here are the compartments that I need you to know and understand. So this is your intracellular compartment, we call that. So the intracellular compartment, and then we have the extracellular compartment, which is this here. So this one, the extracellular, is divided into the vascular compartment, which is all the fluid that sits inside the blood vessels. And then we have the interstitial compartment, which is the area that sits between your cells and the blood vessels. So this is the normal distribution of fluid in your body. Now, there are different type of pressures that you need to know that actually keep your homeostasis, intact. So the different pressures are the hydrostatic pressure, the colloid osmotic pressure. Okay, these are two, and then we have the osmotic pressure. So osmotic pressure, colloid osmotic pressure, or sometimes we call it colloid pressure by itself. And then we have the hydrostatic pressure. Now, inside your blood vessel and outside your blood pressure, we find these different pressures sitting in there. Now, when I say hydrostatic pressure, that is the pressure of the more fluid area pushing that fluid into the lesser fluid area. Okay, so if the pressure in the blood vessels is higher, then the fluid will be pushed into the interstitial fluid. So this fluid will go into the interstitial compartment or space. And from there, from here, it can go all the way inside here because this will become higher. So from a higher concentration to a lower concentration, the hydrostatic pressure works. So this is higher, the fluid will move into the interstitial. If this becomes higher, then the fluid will go inside here, and then the intracellular fluid will increase. And what would happen to the cell if you have more fluid? Does it swell or does it shrink?
Well,
It swells because you have more fluid in here. So you have swelling of this cell, right? Now, if I move fluid from the vascular to the interstitial, a lot of it, what am I going to have here? A lot of fluid here. What do you call that fluid, that accumulation of fluid or increase in fluid in the interstitial space? What's the medical?
Edema?
Edema. Good job. You see how it goes? Now, what would happen to your cell here if you put a lot of fluid in here?
Apoptosis.
Yeah, well, it can rupture, right? It can rupture because the extra fluid in here can cause this cell to rupture. So let's say that this is an RBC blood inside, blood cell inside your blood. If you keep adding more fluid into the blood, eventually that fluid will go inside your RBC. And if when you get into the RBC, then that will swell and that will explode. And then you destroy these cells, the RBCs. So that's why you have to be careful on overhydrating these patients. Okay, we'll talk about the different types of fluids that you can hydrate or, all right. So the other type of pressure that you keep in mind is the colloid pressure. The colloid pressure, switch it with the term protein. So colloid pertains to proteins. So inside your blood and outside, we have proteins. Now the proteins are attractors to fluid. That means what? They suck the fluid in toward them. It's like, remember how salt sucks fluid into them? Or, water follows sodium. Water also follows proteins. So the more proteins you have in a blood vessel, the higher the oncotic pressure. Does that make sense? So proteins takes water in. So the more proteins you have in you, in the blood, the more fluid is going to stay here. And that would increase your oncotic pressure. Good? Same thing here, because we have oncotic pressures everywhere. Inside here, inside here, inside here also. So the movement of fluid, depending on the concentration okay, from higher concentration to lower concentration, or higher pressure to lower pressure. Higher concentration of protein will keep the fluid within the blood vessel if I have a higher concentration, higher colloid pressure. There is also what we call capillary hydrostatic pressure. What is the capillary? What's the capillary?
Like the smallest kind of artery.
Yeah, the smallest blood vessel. It's not an artery, it's not a vein, it's a capillary. Because the three major types of blood vessels that we have is what? Are what? Arteries, veins, and capillaries, correct? So the capillaries usually are the smallest blood vessels that sit where? It sits by the cells. So this is the pressure where it pushes like oxygen inside, it pushes water inside the cell. So if I increase that capillary pressure, eventually I'm going to have a lot of fluid going inside the cell. And the capillary pressure that basically lines the cells right there. See, I have capillaries lining the cells. And from the capillaries there, I'm going to end up having fluid going inside this way. Understood? So capillary pressure has to be within a certain pressure in order for it, for the water to move in or out, or even electrolytes or whatever the cell needs to move from the capillary, from here inside, and then from the cell outside to the capillary. So, so what about osmotic pressure? What do you think we're dealing with when we talk about osmotic pressure? The movement of what?
Fluid.
Water?
Osmotic means what?
Water?
Water. Okay, water, specifically water. So if we move the water in from, usually the water by itself moves what? Higher concentration to lower concentration, right? So if the concentration here, you have more water here, it's going to move inside the cell. If you have more water here, it's going to move outside the cell. So osmotic, okay, is just the movement of plain water. Now hydrostatic pressure, we can move water and other components out. And that's where we can actually damage some of the capillaries and have, different proteins and so on going into the tissue itself. Okay, so osmotic, water, hydrostatic, fluids in general, fluid, moving of fluid, could be with electrolytes also, all right? Because if I move fluid from here outside, I don't only move the water, I move the electrolytes out. So I'm gonna be what? Lesser concentration here, okay? And so we'll talk about osmolarity in a second. You know, it becomes a hypoosmolar. That means the osmolarity in here is lower. All right, so fluid requirements. So what are the fluid requirements? So usually these are the sources that you get fluid from. You drink 1,500 milliliters roughly every day. You should be. So this is like about six bottles of water. The plastic. What is it? How many ounces? About
16.
16 ounces. So these 16 ounces, you need about six of them, 5 to 6 of them to have enough water coming in. From food, you have 800 coming from food. Oxidation, you have 30, and that's when you produce, if you remember oxidation in the mitochondria, eventually we produce water when you go through oxidation process, oxidation reduction process, more oxidation inside the mitochondria. So we produce about 300 that goes inside the cell and other in the cytoplasm also and outside. So we do any type of oxidation you do. So we have about 300 milliliters of water. Altogether, give you about 2,600. That's inside your body. So 2,600, we need to balance how much we bring out. So we can't bring out more and we can't bring out less. If we do less, then we have the retention of fluid. If we send more, then we can become dehydrated. So how do we lose water? 1,500 will go through the urine. The stool gives you 200. These are called sensible, by the way. Urine and stool, losing urine and stool fluids, that's sensible. The others are referred to as insensible. That means they're not the major sources of excretion of water. We have the skin and the respiratory tract and the tears and all that stuff that that you send water out. Altogether is about 2,600. So you're balanced here. So how much you bring water in, you should get it out. When you drink a lot of water, what happened? You're going to end up urinating it. So you're fine, you're good. But many of this water will eventually get into your body, your cells. It's used to move things around, but you don't want to overhydrate yourself because you're going to have problems. So you need the fluids, you need the water to move things around and for all the cells to function well. Without the water, you cannot function. You cannot move things inside and out of the cell. Okay, you need water to move electrolytes. You need water to move proteins. You need water to move for absorption, reabsorption. You need water to defecate, right? All that. Without water, you're not going to be able to do many functions, normal functions in your body. All right, so usually you want to balance your patient, right? So you can look at the intake and the output. So how much? Let's say 26 comes in. You want to make sure that 26 comes out. And then you're balanced. Okay. Now, average adult intake, you're drinking and food about 26, like we mentioned. And the losses, you lose them through sensible losses. Okay. And these are basically urination and feces. 60% is lost through urination. So 60% of the 26, just 1,500, we said, goes through urination, and then 5% goes through the feces, okay? And then the insensible, so all these are like, insensible in general. So we have, through the liver, intestine, sensible, this is a mixed actually. So you have brain, these are where all the water is sitting, everywhere. Okay, so you have water here. You have water in the joints, bones means joints. The skin, you sweat. So when you sweat a lot, what does that mean? That means you're going to lose water. So you lose water and electrolytes. So we should not be giving you only water by itself. We should give you water and electrolytes when you sweat too much. So all these athletes that runs around and they lose sweat, you can't just drink plain water. You have to drink, electrolyte type of water. Okay, so this is your fluid distribution in general. All right, and you have this is just the amount of fluid that covers that organ. Most of your eye have fluid inside, so your eye is filled with fluid. 95% of your eye is fluid. 75% of your heart is fluid, which is blood. The intestine, you have plenty of fluid there. Your brain, 83% is made out of fluid. Kidneys, 83% is made out of fluid. Lungs, 85% of your lungs are fluid. So this is where you find all your fluids everywhere. All right, let's talk about regulation of the fluid. How do you regulate the homeostasis there? What controls how much fluid you have in your body, if it's insufficient or sufficient? So basically, if you these are the different things that controls your body, the body fluid. The baroreceptor reflexes, okay, if you remember, we have them these are receptors that are stimulated by epinephrine. And these are the ones that can control your blood pressure in general. Okay, it's responses to the blood pressure. When you have lower blood pressure, this thing kicks on. When it kicks on, it turns on. Then, and these are found where? You find them in the atria, the vena cava, aortic arch, and the carotid sinus. So these are different areas where you find these baroreceptor reflexes. So when your blood pressure is lower, this one kicks on, okay, and eventually it'll retain the fluid by the kidneys, okay? So the fluid, when it goes to the kidney, eventually, instead of peeing it out, the kidney will keep it inside your blood. So who controls this? The baroreceptor. So when the blood pressure goes down, the baroreceptor reflex kicks in, and then when it does, then all the fluid that are in the area here, of course, all these has fluid in them. When it goes and it passes by the kidney, eventually the kidney will retain all that fluid. That's one way to control water or fluid. The other controller is the osmoreceptors. Now the osmo means concentration. So the osmolality, okay, is the concentration of fluid, right? So concentration means the more stuff you have inside the fluid, the more concentrated you are, the higher the osmolality. So the more sodium I have, the more glucose I have, the more proteins I have, the higher the concentration. So the more electrolytes in general that you have inside your fluid is referred to as osmolality, increase in osmolality. So when I talk about body fluid from now on, what am I pertaining to? Extracellular or intracellular? What do you control, the intracellular or the extracellular?
Extra.
Extra. When you put IVs in people, when you let them drink water, when so anything that we can control what? The extracellular. So from now on, whenever I say fluid or the concentration of fluid, I'm pertaining to what? The extracellular. So the extracellular consists of what? Vascular and what's the other compartment?
Interstitial.
Interstitial, correct. So vascular means blood. Interstitial between the cells. And some of the blood plasma, fluid or water, leaks out to where? To different organs, right? So from there, you have extra fluid leaking out from the plasma outside to give the eye its fluid, to give your joints its fluid, to give the CSF its fluid. See that? And that's where you get all the fluid from. All right, so osmolarity or osmolality, it's used different, sometimes you say osmolality, sometimes you say osmolarity. There's a little difference between them, but so the osmolality, which is the concentration, is controlled by the hypothalamus. So your hypothalamus, you have osmoreceptors there. And they respond to fluid excess. See? So when you have too much fluid inside your extracellular, specifically in the atria and the great blood vessels, and what it does, it just increases the urine output. So when you have too much fluid, it increases the urine output, and then with that, you excrete more fluid outside. So who balanced the concentration or the extra amount of fluid that you have inside your blood vessels and all that? The osmoreceptors. They are the ones that can control the excess fluid in the atria, great blood vessels. Okay, so when I say great blood vessels or vessels, what are we dealing with? Which vessels are the great vessels?
Like the aorta?
Aortas?
What?
Large arteries and veins.
Yeah, large arteries and veins. What? Name a couple.
Vena cava.
Aorta?
Yeah,
Aorta.
yeah. So all that. So who controls all these? How much blood you have inside them? The osmoreceptors. So the osmoreceptor sits right there. And when you have too much fluid inside the atria, too much fluid inside those great vessels, the osmoreceptors kicks in. It tells the hypothalamus, I have too much water, then automatically the hypothalamus will tell what do you think will cause, what hormone causes increase in urine output? Who controls the water, the urine? How much urine comes out in the kidney? What?
ADH.
ADH, antidiuretic hormone, which is down here.
ADH?
Yes, ADH, correct. Okay. So what else can control water or fluids in general? The RAA mechanism, okay? The renin angiotensin aldosterone system, S. So this system right there controls the blood pressure, right? Because when your blood pressure decreases, not only the baroreceptors controls it from the vena cava, the aortic arch, and then the carotid sinus, but your kidneys can control that. And that's through the renin angiotensin aldosterone system. So when the blood pressure goes down, renin is released, your blood pressure goes up, right? And then from there, because you have vasoconstriction. So vasoconstriction happens, then you have increase in blood pressure, okay? And aldosterone also controls it. How does aldosterone controls it? Through what? The absorption, reabsorption of sodium and the excretion of potassium. So aldosterone retains sodium and it excretes potassium out. So when it does that, that's how we control electrolytes in this case. So you have increase in chloride also because these two guys go together, okay? And increase in hydrogen also. And increase in H2CO3, which is carbonic acid, and decrease in bicarbonate, which is a base. We're going to talk about this increase and decrease when we get to electrolytes imbalance. So there are certain electrolytes that goes in and comes out from a cell depending on the pump that they use. And if you remember, we mentioned last time I met you, we have a couple pumps. We have the sodium potassium pump. We have the, the hydrogen potassium pump, right? We have the chloride pump also, okay? And then we have these guys here that actually can produce water and carbon dioxide. So this is a carbonic acid here. We're going to discuss this when we get to acid base. We're gonna see how this guy can dissociate into water. So these two H2 and then one of the oxygen will come together and the CO2 will remain, and then we'll produce CO2 and then we'll produce water in this case, H2O. So this is one of the mechanisms or buffers we call them that can control how much water can come out also. Okay, so all these so far, so we just talked about antidiuretic hormone, okay, also that basically controls how much water goes out and how much water comes in. So you need to understand all this here, which matches what we discussed in general. So if you are not taking enough, you're dehydrated, you're not taking enough water, right? Right away, you have decreased blood volume. When you decrease the blood volume, you have decreased blood pressure. When you decrease blood pressure, you're going to kick in this guy here because it controls when you have decreased blood pressure, renin will come out. Renin will cause vasoconstriction. When it causes vasoconstriction, automatically this guy will stimulate thirst center in the hypothalamus. So it sends in a message to the hypothalamus and it says, hey, hypothalamus, I'm thirsty. You know, and we know that the thirst center is where? In the hypothalamus. So the thirst center increases, you go ahead and you start drinking water. and there you decrease the osmolality. Now, again, osmolality, concentration. Concentration, more stuff you have. Think of sodium. You have more sodium in there. So when I drink more water, I'm going to reduce the osmolality because I'm going to have more water than solutes in there, right? Remember a solute and a solvent? So water is the solvent. Sodium is the solute. So the more clear water I drink, the lesser the concentration in that blood. Okay, are you guys good with that? Everybody understands concentrations and so on, because that's very essential. So let me ask you this: if you eat a lot of salty food, okay, what's going to happen to the concentration of the blood? What happens to the osmolality? Does it increase or decrease?
Increases?
Increase.
Increase, because you have increase in salt, increase in sodium. So the osmolality will increase inside your blood, because all the fluid that you drink, by the way, through the mouth, it is absorbed by who? By the blood. So so the sodium will be absorbed by the blood, and then the concentration will increase. So you're required to do what to balance things out? You're going to be drinking more water. So the more water goes inside the blood vessel. Now, what happens when you drink more water and you have too much salt in there? What happened to the osmolality after you drink the water?
It's going to decrease.
It decreases. What happened to your blood pressure, though?
Increase.
Increases because you have more fluid going in. That's why when we eat too much salt, your blood pressure goes up, because of the water following the salt inside the blood vessel. Understood? So if you keep drinking a lot of water, your blood pressure goes up, but the osmolality goes down. Now the fluid will start shifting. You see? Now we're going to shift fluid from where? Who has the higher concentration now? The blood vessel or the interstitial space?
Blood vessel.
Blood vessel has a higher concentration. So now we're going to be shifting fluid, right, and sodium from the blood vessel back outside where? Into the interstitial. So when we have too much fluid shifting from the blood into the interstitial, what's going to happen to you? What symptom are you going to have? Or what sign it's going to show?
Edema.
Edema, good job. See how you get edema? So where's the edema usually? Is it in the blood vessel or the interstitial space?
Interstitial space?
Correct. Do you have edema of the cell itself? Can you have edema inside the cell? What is edema?
Swelling.
Swelling, increase in fluid, in this case, right? So can the fluid move from the interstitial inside the cell? Yes, it can. So what happened to the cell now?
Gonna swell and can
Swells up and then
burst.
ruptures. Yeah. So it's an issue, isn't it? And that's what happened to your blood vessels, blood cells, RBCs. Too much salt, too much water. You can bust these RBCs and you become anemic. So everything's connected, so you need to make sure that your system is, all right. So you guys are going to deal with a bunch of different fluids. When you work on the floor, there are different types of fluids that you can administer to the patient. We have two major types. Either they are what we call volume expanders or plasma expanders, okay? So volume expanders, that's in general, extra volume of fluid are taken in, right? When I say plasma expanders, I'm talking about proteins. Because if you remember, proteins are what we have inside the cell, inside the blood vessel that takes water in. It pulls water in. So The crystalloids pertains to crystals of electrolytes. Crystals of electrolytes. So here we have electrolytes involved. Here we have proteins involved. So when I say colloid, it pertains to albumin or other plasma proteins. Dextran would be the famous fluid that you give. Now, let's talk about crystalloids. So crystalloids, the types of fluids that you have is either isotonic, hypotonic, or hypertonic, okay? Now, which type of fluid do you think, what does isotonic means, first of all? What does isotonic means?
Neutral?
Neutral to what? Iso means similar. Iso
Like
means
the-
similar.
It's like
Similar to
the
what?
amount. It's like the amount of solvent and solutes are the same.
Like the concentration?
No, when I say isotonic, I'm telling you that this fluid is similar to your body fluid. That's what isotonic means. Okay? So when I give you isotonic fluid, is that safe for me to give you?
Yeah.
Absolutely. It's also called euvolemic. U means what? Normal.
Yeah.
Normal, it means normal, equal. So when you administer fluid that you don't want to harm the patient, normal fluid that you give the patient, you give them what? Isotonic solution. And that's usually is made out of sodium chloride. So it has fluid, water, and it has a little sodium chloride in there. Okay? Now, we have what we call normal saline, and we have what we call lactated ringer. These are two major types of solution that we give when we want to just administer fluid to you. We can't give you just clear water. If we give you clear water, we're going to go into a hypertonic solution type of thing. I'm sorry, hypotonic. You know, when you have, again, so this is similar to the body. Now, if I give you a hypotonic solution, that means what? Lower concentration or high concentration?
Lower concentration.
Lower concentration, that means it has less what? Electrolytes or fluid?
Fluid.
Less electrolytes.
Electrolyte, sorry. I'm sorry.
Hypotonic, less electrolytes. So you have less electrolytes than normal. So watch this. This is 0.9%. This is 0.45%. So I have a lesser electrolytes in this fluid. How about hypertonic solution? What does that mean? I'm giving you what? Stronger than 0.9 or weaker than 0.9?
Stronger.
Stronger. Look at this, 3%. D5W, 5% dextrose. That's what a D5W. Dextrose, 5% and water. So this is, so which one do I give you if you need electrolytes?
Hypertonic.
Hypertonic.
Hypertonic, that's when you really, really, really need it. Is that understood? If you're just barely lost some electrolytes. So, okay, you're sweating, you're running, and you lost some fluid and little electrolytes. What do you think I give you? We would give you isotonic or hypertonic?
Isotonic.
Iso, good answer. Because we have a little salt and, you know, we have, this is the normal stuff that you have. So I want to give you normal stuff. If I give you this, what's going to happen to you? If I give you hypertonic stuff, what's going to happen? What's going to happen to the concentration of the blood? Increases or decreases?
Increases.
It
Increases.
could increase, causing the cell to swell.
Okay, so the outside in the blood, right, will increase and more fluid will follow, correct? If I have more, so if well, let's say I increase the sodium inside the blood. Where is the sodium is going to shift now? Into the cell or out of the cell?
Out of the cell.
So the outside has more sodium. outside the cell has more sodium than inside the cell. You always move things from higher concentration to lower concentration. So eventually that higher sodium will shift inside the cell. Okay, and some of the, well, you know, some of the water from inside the cell will shift where? Outside to balance things out. So eventually you're going to have the cell shrinking. So you lose fluid from where? Intracellular or extracellular in this case?
Intracellular?
Yes. So you move from intracellular to the extracellular. So with that, you have the cell shrinking. So if I give you too much fluid, we're going to harm your RBCs. You're going to shrink, and you're going to be, the RBC is not going to be functional. So we don't want to shrink it, and we don't want to, what? Swell it. How about if I give you hypotonic solution? What is hypotonic again? Lower than what?
Lower concentration.
Lower concentration than normal. So if I give you lesser concentration than normal, okay, where's the fluids going to shift?
Into your cells.
Into your cells. What's going to happen to your cells?
Swell.
They're going to swell. See? So now, many times, when do I give you hypotonic solution? If you lose sensible stuff. So what did we say the two sensible losses that you should have?
Urine and feces.
Urine and feces. So if you are urinating too much, okay, then I can give you this. Because I don't want to give you too much sodium because you're just losing clear what? Mainly water, right? Just a little bit maybe. You should not lose electrolytes inside the urine. So we need to give you a hypotonic. Understood? So in situations where you lose sensible losses, then you use hypotonic. If you are sweating and you lose fluids everywhere, how about if you're vomiting and you're having diarrhea? What do we give you? Isotonic, hypotonic, or hypertonic?
Probably hypertonic, because you're losing more fluids than usual.
Usually we do a blood test and look at your electrolytes, right? If it's too much electrolytes that you lost, then maybe we need to give you this much for a little bit, like D5W, okay? Or this. Now, sodium chloride and glucose attracts water. So that's the whole idea by giving you hypertonic. So when we give you hypertonic, okay, eventually the fluid will move from inside the cell outside to follow the sodium that we gave you, because we gave you a lot of sodium into your blood. So eventually the cell will shrink in this case. Now, when do we use colloids? When do you think we give you colloids?
Blood loss. If there's like a significant amount of blood loss.
Good job. Yeah, if you lose a lot of blood loss, like hemorrhaging, and so we need, because you need to substitute what? The proteins also, because without those proteins that you're in trouble. So when you lose a blood loss, when you lose blood, eventually sometimes we give you a colloid type of blood. We call that plasma expander. That means we need to expand the contents of the plasma. Okay, so these are what comes in the market. This is what you're going to be seeing here. So this is normal, isotonic. This is hypotonic, lesser concentration. It comes as 0.45, 0.33, and 0.2. All right. Now, 2.5 dextrose is considered to be hypotonic, but 5% is isotonic. You see? So how about D10W? Would that be hypotonic or hypertonic, you think?
Hyper?
Hypertonic. Because D5W is 5%, D for dextrose, right? W for water. So D5W is isotonic, which is the normal amount that you have. This one here could be, now it has to be greater than 5%. This one, actually, I want to change this to above 5%, greater than. Okay. So it's greater than D5W here, so to make sure that this is right. Okay, so greater than this would be hypertonic. So hypertonic, either you have too much sodium, too much sugar, protein. But proteins, if I have too much proteins, I go into colloid. I'm not hypertonic anymore. Okay, but it's a hypertonic kind of thing because I have proteins in my plasma. That's what I have. And the plasma proteins will attract water also. All right. So here it says the internists, they like sodium chloride. But by the way, sodium, this isotonic solution does not only have sodium, but it has potassium in it. Lactate ringer, it doesn't have potassium in it. So that's why sometimes the surgeons, they like the one without potassium.
So D5W is isotonic?
D5W by itself, right? Exactly, D5W is isotonic.
Okay.
Hypotonic would be 2.5, half of this. Greater than this, greater than 5%, like D10W, like this one here, will be hypertonic. Okay? Well, here I mentioned a little bit, but this is exactly what the difference between normal saline and lactate ringer. Normal saline has low potassium in it, okay, and high chloride. So if you have low potassium, right? We said potassium is what? Is that a contractor of a cell or is that a relaxer when you have too much potassium inside?
Relaxer?
Relax.
Contractor?
Contractor. Okay, potassium contracts. Remember, you need the potassium to go inside the cell in order to contract. All right, so it has a low potassium, not serious to really go crazy about. That's why we give it to you. But you need to monitor the amount of potassium in there when you apply normal saline. It has high chloride in there. See, it doesn't come, it's sodium chloride, isn't it? So chloride can induce increase in hydrogen. When you have increase in hydrogen, you can end up having what we call acidosis. So it's chloride and hydrogen, they go together. When you send in a chloride molecule somewhere, a hydrogen follows it. Okay? So you end up having what we call metabolic acidosis sometimes in excessive situations. If you overload somebody with normal saline, you're going to actually harm the patient. You have to give them exactly what they need. And there's a formula, again, to calculate how much fluid you need to give that patient. So by looking at the compartments and how much everybody should have, so you need to figure out how much you lost, right? By calculating how much you have left. And there are different formulas to use that, but we're not going to get there. We're not going to that. So increase excessive chloride administration causes increase in H2CO3. Okay, H2CO3 is a carbonic acid. Carbonic acid has a hydrogen, extra hydrogen in it. It's an acid. So this will decrease the reabsorption of HCO3, which is a bicarbonate, into the kidney. And that can lead to, like I said, so when you have extra hydrogen along with the chloride, eventually, so every time we increase hydrogen in your blood, you can get into acidosis. When we get there, we'll discuss acidosis and alkalosis. So this one, if you have an issue, like kidney issues, okay, and you cannot excrete the fluid correctly, you're going to end up having acidosis there, you see? Because this hydrogen will be retained inside your blood. So give lactate ringer, you know, when we need to give you to somebody with renal failure. So with renal failure, usually you give lactate ringer, which doesn't have potassium in there, which balances with hydrogen, if you remember, and the chloride also. All right, septic, and so indication for sepsis. Okay, usually if you're septic, if you're going into hemorrhagic shock, you know, normal saline is good because you need to substitute the sodium in there. So always check volume overload because you're going to end up having pulmonary edema. So all the fluid in the blood will leak out through the capillaries inside your lungs. And some of that fluid will go inside your alveoli and the interstitial area in the lungs. So you're going to have pulmonary edema there. Jugular vein distension. Okay. Again, overloading. You're going to have too much fluid inside the veins also, which you're going to eventually can see that extra fluid inside the jugular vein. You'll have distension there. So this one, lactate ringer, the story is it has a little bit higher potassium. Now, higher potassium you have to be careful with, right? So 2.5 to 5 is normal. It has a little bit below the highest level of potassium, but it has a little bit extra. So people that have low potassium, this is a good solution to give as an isotonic. Okay, so surgeons, they like that because of the potassium, and you know, it causes the heart to beat better also because it's a contractor during surgery. But you can use both, but you got to keep in mind what other things that you know. We have one thing that's called spacing, third spacing. Now, you need to look for that. This is when you have too much fluid going into the interstitial space, okay? Which leads to what? Edema eventually. So when we talk about third spacing, if you ever get a question on the NCLEX that says third spacing, okay? We're dealing with the interstitial fluid. That's the third space. Because you have intracellular, extracellular, a lot of the extracellular, when we say extracellular, we're pertaining to what? The vascular. So we call the interstitial, instead of saying extracellular 2 or something, we call that third spacing. So what is third spacing? Interstitial space. What is extracellular? Vascular space. What is intracellular? Inside the cell. So from now on, when I say third spacing, you know that we're talking about the interstitial, but it's part of the extracellular. So this can cause potentially serious problems such as edema, reduced cardiac output, and hypotension, because everything can, if you move the fluid from the extracellular, which is the blood vessels, into the third space, eventually you're going to have swelling in the third space and then edema. You have less blood flowing, so you're going to have reduced cardiac output and then hypotension. When you have less cardiac output, you eventually have hypertension automatically. So when do we move this fluid into the third spacing? Eventually all that can move into different cavities, open cavities. These open cavities like peritoneal cavity, pleural cavity, synovial cavity, and the alveoli. So you're going to have ascites, peritoneal cavity. When you have extra fluid in the peritoneal cavity, you call that what? Ascites, if you remember. So ascites, extra fluid in the peritoneal cavity. If I have too much fluid in the pleural cavity, what do you call that? Anybody?
Pleurisy?
Pleurisy is what? Inflammation of the, yeah.
Is
So
it
what's the other?
pulmonary?
What?
Is it Pleural effusion.
Pleural fusion. Good job. So pleural fusion is different than, don't confuse pleural fusion, by the way, with pericardial fusion. I have this on the question on the test. So what is pericardial effusion?
So like a fluid buildup in the pericardial sac.
That's correct. Pericardial space, in the pericardial space. Okay. Pleural fusion, fluid accumulated where?
In the pleural.
Pleural lung. See, pleural lung, pericardial heart. And where are your synovial cavities?
In your joints?
Joints. And then you're going to end up having some fluid going into your alveoli. You should not have fluid inside the alveoli, right? You should have only what? What do you have inside the alveoli, usually?
Usually actually going in.
Air, right? You have air. You breathe all that air in there. And that air has oxygen in it. Oxygen goes into the blood and then CO2 comes out. So that air, you should have air, not fluid. So if you have fluid inside the alveoli, what problem can you have? What do you call that problem?
Is that pneumonia?
Pneumonia. Good job. So you should not have fluid inside the alveoli. If you have fluids inside the alveoli, you end up having pneumonia, and then bacteria will come, and then you have pneumonia. You have bacterial pneumonia. So with the virus, this COVID, that's what happened to these patients. They build up fluid edema in their alveoli, and that's why they can't breathe. So, all right. So what interventions can we do? Well, you monitor the patient. Fluid shift may resolve within 48 hours if usually within 48 hours, you observe for 48 hours. If it shifts on its own, then we're good. If not, it can lead to edema and then eventually ischemia because you don't have enough oxygen or fluid from the blood vessels going to the area, and then that tissue can eventually start dying. So closely monitor vital signs, urine output, peripheral perfusion. What does peripheral perfusion mean?
It's just the distribution of blood through your tissues.
Yes. Your perfusion is the amount of blood going into the tissue, basically. Look at the mental status. Why do we need to watch for mental status?
To make sure there's not potentially other life-threatening issue happening, like if I'm correct, myocardial infraction.
Mental status. What is mental?
You could have like cerebral edema, maybe?
Yes, we're worried about cerebral edema there. Absolutely. Ventilation and perfusion status. Ventilation, we said what? What's ventilation?
Breathing?
Yeah, ventilation is the amount of air going in and out of your lung. And perfusion, we said, has to do with what again?
Isn't it the gas exchange in your lungs?
It's actually the amount of blood that goes to your lungs or tissue. I think Aaron or Sam just mentioned that a minute ago. So how much blood are we perfusing? What is the exchange of oxygen and CO2 refers to? What is the term that we use when we push the oxygen through the capillary, in or out?
Gas.
What?
Respiration.
Respiration. Okay, respiration is the process, but the term itself, like perfusion.
Gas exchange?
Gas exchange, but we have what we call diffusion. It goes through the diffusion. So we diffuse the gas, okay? We perfuse blood. We diffuse gases. So gases can diffuse, okay? So oxygen diffuses through the capillary. CO2 diffuses through the capillary. Blood perfuses into the tissue, okay? Respiration is the exchange, both exchange, going in and out together. That is respiration. And ventilation is just basically the air reaching that area, reaching your alveoli. So you have good ventilation when you have all that air getting into your alveoli without any issues. Okay, keep those terms in your mind. All right, we have hematocrit, hemoglobin. Why do we have to monitor the hematocrit, and why do we have to monitor the hemoglobin?
Wouldn't it be because if there's extra amount of fluid in your interstitial space, you're gonna rupture your blood cells?
Yeah, because, well, if you have fluid coming out of the blood vessel, okay, so you have less fluid, then, you know, some of the fluid from the cell will come out, and then they kind of collapse, because always, you know, it moves from the higher concentration to the lower concentration. And hemoglobin, so hematocrit is the percentage of RBCs, so we're going to have less RBCs probably going on here. And hemoglobin is the protein inside the RBC. And serum electrolytes, we have to balance this out also. So this is what you need to monitor when you're dealing with fluid shifting and all that. Okay. All right, now we're going to get into the chart and look at different types of imbalances that we can have. So let's look at it. All right, so all right, so this is what you'll be doing all day long. You know, balancing fluids, making sure that everything is right. So 3 things that you look at: dehydration or hypovolemic, overhydration or hypervolemic, or water intoxication. So what is that? What are the differences? Now, when you are dehydrated, that means you have less water or fluid inside your blood vessels and the third space. But in general, the blood vessels. So if you have less fluid in the blood vessels, okay, and the third space, then the concentration is going to go up. So you have hypertonicity. Okay? So hyperosmolality or it becomes a hypertonic. So when I say hypertonic solution, I'm dealing with what? Higher or lower concentration?
Higher concentration.
Higher concentration, yes. Now, don't confuse tonic. Some people think of tonic as water. So they think, oh, it's too much water. It's the opposite. When I say hypertonic solution, it means what?
Isn't it like too much electrolytes?
Yes, higher electrolytes in general. And the major electrolyte that we look at in this case is what? Sodium. Okay? Sodium. When we give you sodium chloride as normal saline, okay, it has sodium in there. And that's the most important, you know, one of the most, all of them are good, but sodium is the one that has a lot to do with what? With balancing fluids. What is the other electrolyte that balances fluid?
Potassium?
No.
Chloride?
Chloride, good job. So chloride, sodium chloride, here we go, sodium chloride. Both of them plays a major role in controlling your fluids, okay? So dehydration, hypertonicity, or hyperosmolality, you can say, same thing. Now, if you are overhydrated, overhydration, that means what? You have more water than solute. When I say solute, I'm pertaining to the sodium again, the concentration. So that is, it becomes a hypotonic solution because I have more water than salt. Hypotonic. Now, what is water intoxication? What is water intoxication?
When you have too much water in the system compared to solutes?
Yeah, when you drink plain water, lots of plain water. See, some of the athletes, what do? Drink plain water. They drink like 10, 15 bottles of water a day. What's going to happen to them? They're going to end up having what we call water intoxication. You should not drink plain water more than what you need. So with this, if you have too much water there, again, you become what? Hypotonic. Why? Because you have more water than electrolytes in there, or sodium, right? And then, you know, both this one and this one kind of similar. Both of these kind of similar in side effects and so on, but you can have issues with water intoxication due to some certain problem in your body also, not only just drinking too much water. So drinking too much water is one of them. All right, let's go into mechanisms first. So when you're dehydrated, you're taking too much, you're losing a lot of fluids, okay? Okay, so eventually the clear water comes out, sodium stays in the blood, you become hypertonic. So decrease fluid, extracellular fluid, increase extracellular osmolarity, and then increase extracellular sodium. You'll have a fluid shift out of the cell because now you have more concentration in the plasma than inside the cell. So you're going to have fluid shifting from the cell outside, and you're going to end up having what we call cell shrinkage. And when you shrink the cell, you destroy the RBC or the other cells from the interstitial cells. Okay. So again, we're going to look at the cells, your body cells, not only the RBC. So the extracellular usually move to what? From extracellular to what space does it move automatically? If I'm going, look, extracellular, third space, intracellular. I'm moving from extracellular toward the intracellular. I have to pass by what? By the third space first. If you get stuck in the third space, you end up having edema. And if you have too much fluid there, eventually that fluid is going to move inside the cell. And that cell is going to explode. If it's backwards, if I have less fluid inside my blood, the fluid will shift from the third space into the blood vessel. And some of the cell, the fluid inside the regular cell, tissue cell, will move into the third space, and from a third space, eventually to the blood vessel to balance things out. So your body wants to balance things out. It shifts fluids depending on what compartment has less fluid. So either you go into the cell or you come out of the cell, depending where did you lose the fluid from. Okay? So hypovolemia, isotonic fluid loss, all right? So isotonic, so sodium chloride, from the extracellular space can progress to hypovolemic shock. So you can, if you lose too much fluid from the extracellular, eventually you can go into a shock. That's how people passes out when they become dehydrated. All right, so overhydration, you have increase in extracellular fluid. You add more fluid, more water. Decreased osmolarity because you have now more fluid than sodium chloride. So you have less sodium level. The fluid will shift from the shift into the cell to restore balance, and then the cell will swell. Okay. So this is the opposite of this, and this one's similar to this, but we have more water than normal saline. This one is basically normal saline because you're losing here when you overhydrate someone. Mainly, a lot of it has to do with the same fluid of your body shifting from one place to another, along with the electrolytes, not only the fluid by itself. So let's look at causes and risks. So when you have, this is dehydration here, excessive fluid loss, let's say hemorrhage, decreased fluid intake, and then you have the third space fluid shifting automatically. So less fluid inside the blood vessel. You shift from the third space into the inside the blood vessel. And it's due usually, so when do you shift from third space to, what abnormality I shift fluids from the third space into the blood vessel? What do you think? When can I shift fluid from the third space into the well, here, they're talking about blood, fluids going from the extracellular, which is the blood vessel, to the third space, and then from a third space, eventually goes to the cell. So in that direction, that's where we go. But it can go back that way to maintain things, but it's not, dehydration is caused by the third space fluid shifting from it, usually goes in the direction of the cell or outside. Okay. How about if you lose, what kind of fluid can you lose too much from a third space? What did we say some of the insensible fluid that you have, that you can lose? How about diarrhea? Diarrhea, you lose that. That's third space stuff, even though it's in the intestine, but that's part of the insensible fluid. You can become dehydrated if you have diarrhea. You can become dehydrated if you have vomiting. So let's say, vomiting, right? And then diarrhea, right? So either one of these will give you a shift of the third space fluid.
So is that why you check skin turgor for like one of the first signs for dehydration?
Right. Yes. What is skin?
I think it's TUGOR.
TU, that's what I'm saying. Yeah, turgor. Mm-hmm. What is listen? How do you spell turgor? TUGER?
It's
TUGOR.
TUGOR?
Yeah.
I think it's TURGOR.
TUR.
TUR.
Yeah, TURGOR.
Got you. All right, good job. So when you do this, when you check this out, what is this again? When your skin is what?
It's tenting. It's
It doesn't
dehydrated, right?
go back to its original.
Yeah. So you grab a flap and you pull it up and it stays there. So you know that you have dehydration there. All right. So what is bedridden has to do with dehydration?
less activity equals less fluid movement.
Yes. Yes. That's why you got to move these patients all the time. You can't just let them stay bedridden. In order to metabolize things, in order to move things around. That's why when you're at night, your metabolism slows down. When in the day, because of the exercise and all that you need. Infants dehydrated, why is that? Why infants can be dehydrated easily? Because they're full of what?
Lots of fluid.
A lot of fluid. So if percentage-wise, they should have plenty of fluid. So a little bit extra loss of fluid in infants makes a big difference, more difference than adults. because you got to have more fluid in the infants. And so if you lose the same amount of fluid in infants as much as adults, the adults could be okay with, but the infants could be harmed, because percentage-wise, you have to have more fluid in infants than adults. Elderlies. Why elderlies? If you lose, so do you have less fluid in elderlies than adults, or more?
Less.
Less. Less. So again, a small amount of dehydration in elderlies can make a big difference to them than adults. Enteral feeding, what is that?
Isn't that through the nose? It looks like an IV kind of, and
Yeah. Yeah, feeding tubes, we call that. You know, so you put the feeding into the nose and eventually into the stomach, and you feed them through tubes. So if you give them too much proteins, you see, because what you're feeding them is just liquid that is balanced. You're giving them proteins, carbohydrates, and so on. So if you give them too much proteins, then eventually all the fluid is going to come and follow the protein inside their stomach, and they're going to become dehydrated, because all the fluid can come from the third space into the extracellular space because of the too much fluid that you have, too much protein that you have there. All right, how about when you have overhydration? So overhydration, you have more fluid than electrolytes, okay? So if you have too much fluid in the extracellular space, usually occurs when compensatory mechanism failed to restore fluid level. Okay, so if there's something went wrong with the compensation, and remember the mechanisms of compensations? Remember the chart that I showed you at the beginning? You know, the hypothalamus, all the different types of factors that controls your fluid. If you have any issues with them within those factors, you can end up having, overhydration. So heart failure, right? Can you have heart failure because of overhydration?
Yes.
Yeah, especially congestive, right? So think of congestive heart failure, and eventually you're going to have plenty of that blood leaking. If you have too much blood in the chambers, eventually they're going to go into the third space in the muscle, and then it's going to sit there. And by sitting there, you're going to have congestion and enlargement of the muscles of the heart, especially in the right ventricle, because everything kind of backflows to the right ventricle in congestive heart failure in general. What about cirrhosis? What is cirrhosis? Cirrhosis is what? What is it? It's caused by excessive alcohol, but what is cirrhosis compared to, let's say, hepatitis? Or cirrhosis is what? Is that permanent damage, or is it
Yes.
permanent damage?
It is permanent damage.
Yeah. Mm-hmm. Damage to the what? The liver, right?
To the liver.
So we have permanent damage to the liver. Permanent. Permanent damage to the liver, often caused by excessive alcohol. Okay, so now why can we have overhydration if we have cirrhosis of the liver? Is that sensible or insensible fluid that we lose? We have insensible fluid lost in the liver. Okay, and the liver eventually is one of the organs that a lot of the blood goes through it, if you remember. So if cirrhosis of the liver, it's going to lead to not having enough fluid inside the hepatocytes, and all of it is going to stay outside. All right. Ascites is what? What is ascites?
It's a swollen belly.
Yeah, and that's, if you remember, we talked about this fluid going into the spaces between the, within the peritoneal space, right? Peritoneal space. Okay, diabetes. Okay, can you overhydrate with diabetes? Or kidney failure? How about kidney failure? Oh, you know, both, you can make sense out of these, right? So how is kidney failure can lead to overhydration?
Because
You can't excrete the fluids properly.
Yeah, you cannot excrete the fluid and then you have issues. So the same thing as nephrotic syndrome. What is nephrotic syndrome? Anybody can guess? I'm going to cover it next chapter, but anyone can guess?
something wrong with the nephrons.
Yeah, something wrong with the nephrons, right? And usually you have like excessive proteins in the plasma. And when this happens, then you have excessive proteins, also all the water going from the interstitial into the plasma, which is causing overhydration in general. All right, here with water intoxication, all right? Now we know that we cause electrolytes imbalance because we were drinking too much straight water, or we can give straight more plain water. You know, when we give you hypotonic solution, all right? By the way, iatrogenic errors, that means what? Caused by you, caused by us. So iatrogenic is, let me take this out first and put this here, and then we'll, yeah. So yeah, with doctors, nurses, and all that, when they infuse the wrong solution in there, okay? So if I give you, you know, hypotonic, eventually it's you know, it has less concentration of solutes in there, right? And more water, so that's going to even make it worse, right? So hypotonic solution, too much hypotonic solution can lead to intoxication. NG irrigation, okay? Nasogastric irrigation, when you irrigate the stomach or the nasal, you know, with clear water, that can lead to that. Enemas, you know, using too much enema can lead to water intoxication, because it's all water here. And if you overuse it, can lead to that. Because right away, when you inject water into the GI, all that water is going to be absorbed into the extracellular. And now, you know, you're going to become hypertonic automatically. Hypotonic, I'm sorry, hypotonic. Okay, what about, okay, psychogenic polydipsia. What is polydipsia?
Very thirsty.
Yeah, you know, you always feel like you want to drink more water. So you have excessive tap water drinking, you know, due to your mental telling you, I got to drink more water, I got to drink more water, okay? And this one is SIADH. What does that stand for again? So when you have inefficiency in the ADH trying to reabsorb water, you know, that's an issue here. All right, so what is, all right, so some of the clinical manifestation, what do you see with these people? So if you have dehydrated people, you get what we call, this is called what? When your eye, you know, looking like this.
Sunken eyes.
Right. So it's called sunken eyes. That's when your upper lid drool down like this, droops down. So it's sunken eyes. And also when you have your eyeballs sunken inside, they sink inside your eye. So instead of being normally, they're sucked inside the socket. That's where You know, that's where you have sunken eyes. And usually this is due to dehydration. So if you see somebody's eyes sunk inside their eyeball, they could be dehydrated probably. So CNS irritability, confusion, dizziness, weakness, extreme thirst. So that's dehydration, all this. Decrease urine output, fever, dry skin, mucous membrane, sunken eye, poor skin, turgor, here we go. Tachycardia, coma, okay. Why would you get tachycardia with dehydration?
Just trying to compensate for like the change in blood pressure.
Yeah, I mean, it's trying to compensate change in blood pressure, and then you're getting, you know, the hypothalamus is telling the heart to beat a little faster, because thinking that when it beats faster, that means, because you have less blood reaching the tissue anyways when you're dehydrating. So the tachycardia is just to compensate, to get more fluid, blood to the tissue. All right, what about if you have, you know, overhydration, you know, hypotonicity. So if you overhydrate, these are some of the symptoms. So you're going to end up having a pulmonary edema. Now you're going to get pulmonary edema in both, actually, intoxication and hypervolemia. Tachycardia, tachypnea, you're going to be short in breath. When you have pulmonary edema, you're not going to be breathing well. You're going to get crackles. Okay, crackles is always relate crackles to pulmonary edema, you guys. That term, that's auscultation. If you hear crackles, you know, then eventually that is due to the fluid inside the alveoli. You know, you hear a little rumbling type of crackle type of sound inside the alveoli. Cardiovascular, we have rapid bounding pulse, hypertension because increase in fluid, S3 gallop. Okay, again, the gallop is the sound that you get due to the ventricular filling slap sound after S2. So after S2, we get an S3 gallop. So after S2, the S2 is what? The closure of the semilunar valves. After we close them, we hear a little sound that is referred to as S3 gallop, and that's basically the flapping, you know, of the filling of the ventricle. Okay, you're going to have increased pulmonary artery pressure due to the increased, due to the edema and the due to the increased amount of blood fluid in the blood, and then increase in the wedge pressure. Pulmonary wedge pressure is the pressure within the pulmonary arteries there. So we do a Swan-Ganz procedure to measure the wedge pressure in the pulmonary artery, and sometimes we have dilatation of the jugular vein, JVD, congestive heart failure, CNS, increased cranial venous pressure, edema, acute weight gain. So you need to weigh the patient all the time, you know, when this is happening. You know, so make sure that you don't want this to happen, you know, because of that. So pitting edema, and then so here are some causes of the edema that you can get. Why would you get some, you know, again, the physiology that I mentioned, increased capillary, hydrostatic pressure can push the fluid from the vascular into the interstitial, increase interstitial fluid, colloid osmotic pressure. So if you increase the protein in the interstitial, fluid is going to follow, and that would increase edema, cause edema. Blocked lymphatic drainage. So again, if you block the lymphatic drainage, all that lymph is going to escape into the interstitial space, also the third space. Decreased capillary colloid osmotic. So if the capillary colloid, which is the protein, decreases, then you have less fluid going into the capillary and more fluid into the interstitial. Okay, so this is just common sense of what happens usually when this happens. With intoxication, same thing. Intoxication, you have, again, too much fluid, clear water reaching different areas, including your brain. You have nausea and vomiting, by the way, because of that. Okay. Low level of consciousness, nausea and vomiting. Why do you have nausea and vomiting if you take too much water?
Because your body's trying to get rid of the water.
Absolutely. Good job. So muscle weakness, twitching. Okay. You know, you get twitching when you're, you know, when you have too much water in your body. Cramping. Okay, you can get that. Again, these are just signs of increase in lactic acid. Okay, when you have increased lactic acid because of the water that you have, eventually you have cramping because of that. Later on, you're going to end up having shortness of breath because you can have edema in the lung, bradycardia, wide pulse pressure, seizures, coma. You can go in any of that. All right, let's look at management. What do you do in general with these? And then, you know. So management, here, if you are dehydrated, you want to give what? Isotonic. Now, hypotonic, depending on what? The severity of the condition. So isotonic, usually if you don't have major shift, okay, just straight loss, then you give isotonic, which is normal saline in general. Now, hypotonic solution, you know, like you give half of this if there's a fluid shift, okay? So if you have a fluid shift from hypotonic to a more concentrated solution, this is to just, if you want something to shift. If you want to shift fluid, you give hypotonic. If you don't want to shift fluid and you want everything to stay the same, then you give isotonic. All right, and you need to be careful with the cell swelling and, you know, well, if you have, of course, you're going to have cell swelling if you are dehydrated, and then the fluid from the cell will go back into the extracellular, into the blood vessel, and then you balance things out. Okay, so 0.45 would be the your choice here. Can you give albumin? You can. That's in if you lose blood. So for blood transfusion, hemorrhage, you can give dopamine. Dopamine just to maintain the blood pressure, basically, it increases blood pressure. These trousers, okay, and these are what? Pressure trousers. Usually if you're in a shock, they put these pressures on, you know, just to maintain, make sure to continuously measure the blood pressure, and also, you know, you increase the pressure around the, to promote what? To promote the blood circulation going up to the heart and the brain. Always assess for fluid overload. Be careful, you know, don't overload these, you know. And with the same intervention, monitor systems and vital signs, maintain urine input and output on dehydrated patients, maintain IV access, daily weight, skin, and mouth care. Okay, if you overhydrate someone, okay, if you overhydrate, then basically, again, fluid and sodium restriction, because you know, you don't want to, you know, overhydrate them more. Give diuretics, and diuretics would be what? When you give diuretics, you excrete a lot of the extracellular fluid, you pee it out. In severe situations, you want to give 5% dextrose in normal saline, and or a little bit higher than that. You know, you can give a hypertonic in severe situations. You give hypertonic, that means the fluid will eventually will go out into peanut because you'll have too much so you need sodium restriction, basically. That's what you need. All right, so yeah, the intoxication, again, just prevent from giving straightforward water to the patients, and always assess how much input and output, and make sure the vital signs are there. Okay, so we're done with the fluid balance and imbalance. Any questions on that? Now, I will set up starting. Let's see here. Maybe so Monday. I'm gonna need Monday to finish the electrolytes, and then we're gonna go into acid base. So we're not gonna have this exam until maybe Friday of next week, Friday and Saturday. So but I will set up tutoring next week, because when we get to acid base, it will be a little bit challenging. So I'm going to do probably acid base before I do electrolyte balance, because it requires problems. You have to solve problems. So it'll give you more time to practice. But if I were you, over the weekend, watch some videos about acid-base balance. Look over the chart that I gave you, just to make sure that you understand as much as you can. And then just be prepared for next week when we cover that. So your pharmacology exam is open already. 10 o'clock it opens. So in about 15 minutes, it'll open up. You can take that anytime today and tomorrow. Yeah. Otherwise, at 12 o'clock, we're going to meet at 12 instead of 12:30. So we'll finish by 2 or maybe less, depending on when we finish. And is 12 okay with you guys? Is that fine instead of 12:30?
Yeah. Mm-hmm.
Okay.
That's fine.
Yeah.
So we'll do 12, and then we can finish as soon as we finish the chapter there. Maybe less than that. It depends on how much we finish. And then that exam will be next week also sometime. We'll see how much we finish.
Will this chart be posted?
It is posted, but I will send this one as an update. Yes, I will do that. Yeah, I'll post it right now. So I'm going to save it and then post it for you.
Dr. J.
Yeah.
You just said that our pharm test was opening, but it's our patho exam, correct?
Oh yeah, patho.
Okay, just
Today patho.
Yes, just.
I said pharm. Yes, I'm sorry.
No, it's okay.
Yeah.
Just double checking.
The patho exam. Patho exam.
Okay.
Yes.
And then for the will the pharm exam be scheduled for this weekend then?
I'm going to try and separate them, for you, so you have time.
Okay.
So I could, if I finish today, okay, then I can give it to you probably Tuesday and Wednesday or something.
Okay.
Let me see if I can finish it. And if I do finish it, then maybe during the week, and then the other one could be a weekend thing, for
Okay,
this.
sounds good.
Yeah, this way I'll separate them. We'll do one during the week, one during the weekend. I'll have a little space there for you. Some students wanted that way, so we'll go with that. Give you a little study space.
All right, thank you.
Sounds good. All right, guys. So I recommend you coming to the next 2 classes, because it needs you thinking and solving things. So make sure you show up for the next 2 classes at least. Okay? All right, you guys. I'll see you at 12 then. All right. Take care.
Thank you, Dr. J.
You're welcome. See ya.
Thank you.
You're welcome.